Hello, this is Daniel Wolff from Regensburg. I'm presenting the summary on Workgroup 4 of the NIH Consensus 2020, which focuses on highly morbid forms of chronic graft-versus-host disease. Approximately 1/3 of the long-term survivors after allogeneic transplant suffer from highly morbid forms of chronic graft-versus-host disease. And that's the major limitation of allogenic transplantation besides severe acute graft-versus-host disease. And the Workgroup 4 focuses on manifestations of chronic graft-versus-host disease which are either frequent or non-reversible or impair quality of life, or are associated with increased mortality. Some of those morbid organ manifestations may be already non-reversible early in the course, which is the case in ocular graft-versus-host disease, or may serve as prognostic gatekeeper for subsequent mortality, which is the case in gastrointestinal manifestations. One problem with chronic graft-versus-host disease is that despite the known heterogeneity, chronic graft-versus-host disease is currently treated in a homogeneous fashion, independent of time point, biology. So we do not make difference in treatment in cases of inflammatory conditions versus fibrotic conditions. And we also apply no organ-specific treatment. So we treat usually skin the same way like we treat eye and lung disease, acknowledging that there may be a different biology behind. So in Workgroup 4, we focused on organs, as mentioned, who are frequent and morbid, which is the case in advanced skin sclerosis and fasciitis, which cause a lot of morbidity, but less frequent mortality. In lung disease, morbidity and mortality is a problem, while in gastrointestinal GvHD disease, mortality, subsequent mortality, not due to GI GvHD disease, but to other causes is a problem. Ocular GvHD disease is a problem which lasts lifelong usually and causes a lot of morbidity. And we also discussed new approaches in trial design to target morbid conditions. In summary, we suggest for the future to phenotype chronic graft-versus-host disease on a biological base within cohort studies to describe the incidence, predictive factors for the subsequent course, mechanisms of organ damage, and the natural history of those highly morbid conditions, applying common definitions in research sample collections. We need to develop new approaches for early identification and treatment of highly morbid forms, including biological targeted treatments with a special focus on prevention and treatment of fibrotic changes, since once fibrosis is established, it's hard to be reversed. And it's usually not responding well to classical immunosuppressive approaches, and alternative approaches to target fibrotic changes are required as well, which may target on alternative cell populations, and T cells may be not as prominent in the pathogenesis of fibrosis compared to the early forms of chronic graft-versus-host disease. We also need to think about new approaches in trial design. As already mentioned, we need to establish primary endpoints for clinical trials in relationship to the time point of intervention. So a clinical trial in early graft-versus-host disease may require different primary endpoints than late, as for instance in early graft-versus-host disease. Complete and partial remission is highly relevant, while in late fibrotic manifestations, a complete remission is basically not achievable and should be a goal, therefore. And for those patients, lack of progression or improvement in functioning, physical functioning and quality of life may be much more relevant and a more realistic endpoint for the clinical trials of in highly morbid manifestation Of course, those endpoints depend also on the organ of intervention, and it's obvious that an trial focusing on ocular GvHDs requires different endpoints than for lung GvHDs. Overall, we hope to achieve through the next 5 to 7 years, by applying the proposed research agenda, significant progress in the field. I have to add that we also now have observed a development of new treatments which already enter clinic within clinical trials. And 2 of those agents has been just presented at the last meeting, which hopefully will change the course of the disease. Thank you very much for your attention.